Well, greetings, everyone, and welcome to the EKG case for the week of February 3rd, 2014. And this week, we've got a great case sent from Parkland Hospital by Dr. Melissa Sarton. Melissa actually sent this case probably at least a year ago, and I've finally gotten around to doing it. It's a really interesting case. Actually, when she sent it, she was a second-year resident. Now she's a third-year resident, soon to become a fourth-year resident. And I also have to give some props to the residency at Parkland Hospital. It's a great residency, and I've gotten a lot of fantastic 12-lead EKGs from the residents at that particular program. So thanks to all of you for your contributions to my lectures and to the video series and everything else. So great work to the faculty at Parkland. And anyway, let's take a look at this case that she had. She had a 57-year-old male who presented to the emergency department with some lightheadedness. The patient had near syncope, shortness of breath, feeling very, very weak and near syncopal. And, well, for good reason. This patient has a history of leukemia, diabetes, CHF. Patient's on insulin and digoxin. Had chemotherapy 4 days earlier, and I guess intermittently was getting blood transfusions. The last blood transfusion was 3 weeks earlier. So, you might be thinking maybe this person's dehydrated from the chemotherapy. Maybe the patient's dehydrated or having some problems from diabetes. Maybe the patient's digtoxic. Maybe the patient's anemic. So many possible reasons why this patient is feeling pre-syncopal, feeling very weak, and so on. The patient didn't have any chest pain or any palpitations. And what else was there? On physical exam, the patient was pale. Heart rate in the 20s. That's a problem. Heart rate was about 25 to 30, and the patient had a borderline blood pressure. Systolic was maybe around 90 to 100 or so, so not frankly hypotensive, but not such a great blood pressure, and no surprise, with the heart rate of only 20, he's lucky to have any blood pressure. The patient was actually awake and alert despite the heart rate and blood pressure. He had a non-focal neurologic examination, and I'm not trying to hide any information. There just wasn't any key stuff on the neuro exam that's worth talking about. And on the rest of the examination, aside from the fact that the patient was bradycardic, really nothing else notable on the cardiac or pulmonary exam. The patient did not appear to be in acute heart failure or any focal lung findings. So we start out getting a whole bunch of labs, the CBC, the Chem 50, get any lab you can think of in a patient like this. And the quickest, cheapest, fastest test you can get, and the test which is obviously most relevant to us here, since this is an EKG video series, we're going to get an EKG. How about that? All right, and here's the 12-lead EKG. It's pretty slow, right? Let me see. What is the heart rate here? The heart rate's 300, 150, 100. It's just slow. Forget trying to count this thing. It's really slow. It's in the 20s or so, and there appears to be, there's low voltage, and I don't know the reason for the low voltage. Let's say we do a quick bedside echo to make sure there's no pericardial effusion or pleural effusion, and that turned out okay. So we're not going to focus on the low voltage in this particular case. We're going to focus on the rhythm and AV blocks and other such things. The patient has what appears to be a left bundle branch block, right? The patient's got a wide QRS with no R, in fact, right there, deep wide S waves in V1, V2, V3, no Q waves laterally. That's also typical of a left bundle. It's not a classic left bundle, because normally with the left bundle branch block pattern, we expect the patient to have a leftward axis. This patient doesn't have a leftward axis, but it's kind of left bundleoid. Okay, we're going to make up words here, but it kind of looks like a left bundle. What about the rhythm here? Well, I see a P wave there, and I see another P wave there, and I think that's about it. There's a long PR, so it looks like there's a first degree AV block for sure, but I don't see any P waves out here. And if you're thinking maybe there's P waves buried in the T waves, well, that's always a reasonable thought, but nothing maps out after that. So there's no P waves that map out after that. So it just looks like there's a P wave there with the first degree AV block and a P wave there with the first degree AV block, and then the P waves decide to go AWOL. And the patient has a left bundleoid type of pattern. It's kind of a bizarre Brady dysrhythmia. Wait, what did I just say? Did I use the word bizarre? What have we talked about before? Whenever the word bizarre pops into your head when you're looking at a rhythm, especially with bizarre Brady dysrhythmias, and probably true also for bizarre tachydysrhythmias, there's something that you've got to think about. Bizarre in emergency medicine equals hyperkalemia. Bizarre in emergency medicine equals give them calcium and maybe some sodium bicarbonate as well. If you see a bizarre patient walking down the street, you know what? Just give them some calcium. What the heck? You're not going to hurt them. You might just make their bones a little bit stronger. All right. So one of the things you've always got to think about when you see just bizarre looking Brady dysrhythmias, bizarre rhythms in general, is think about hyperkalemia. Now, I have the luxury of knowing what the diagnosis here was, and it did certainly turn out to be hyperkalemia. So it's easier for me than it was for Melissa in this particular case. But just to recap, the EKG findings of hyperkalemia, everyone knows about peak T waves and widening of the QRS, and maybe you know about prolonged PR. Hey, this patient did have a prolonged PR, and in some areas even lost the P waves. This patient didn't have a tachycardia, but the patient did have strange AV blocks. Actually, let's circle what this patient has, right? Loss of P waves, prolonged PR, wide QRS. And you know what? Let's go back. Were there peak T waves? Maybe. That might be a soft call, so let's not bother circling that. The patient's got what appears to be a new bundle branch block. So this patient has quite a few findings of hyperkalemia when you look at the list of things that hyperkalemia does, and yet, you know, most people would look at this and hyperkalemia is not really jumping out at you, because most people, first, second, and third, look for peak T waves. And you don't always have gigantic peak T waves. Sometimes you need to know about these other findings of hyperkalemia. And also, let me just write that down. The word bizarre. I can't spell bizarre, apparently. B-I-Z. I always forget whether there's two Z's or two A's. I don't know. Anyway, whatever. Bizarre. This patient's rhythm is bizarre. Let me erase that. Okay. So let's move forward. The patient's potassium was 6.9, so it's not horrendous, but in a person who's not normally accustomed to being hyperkalemic, not normally a renal patient, 6.9 can be pretty significant. This patient also had a uric acid level of 20.4. That's way elevated. LDH is high, phosphorus is high. The patient's in acute renal failure, probably a bit acidotic. Calcium is just a little bit low. Digoxin level is top normal. Well, in a patient with leukemia who recently had chemotherapy and has a uric acid that's off the chart, well, you know what the diagnosis is. This turned out to be tumor lysis syndrome, with the patient presenting with hyperuric acidemia, I don't know if that's a word, and hyperkalemia as well. Tumor lysis syndrome, pretty cool diagnosis. Unfortunate for the patient, but it is a very treatable diagnosis, and Melissa did a great job treating this patient. The patient got IV fluids and some more IV fluids and some more IV fluids. And then for the potassium, got insulin dextrose and some bicarb, some albuterol, and also got calcium, and I highlight that for a reason, and we'll talk about it in just a second. And with this therapy, the QRS narrowed, the rate improved, the EKG turned back to normal. Bundle branch went away. The heart rate picked up back to normal, QRS narrow. And then the patient later got treated further with rasviricase for the tumor lysis syndrome. Now, I highlight the word calcium there because remember, this patient was on digoxin. And a lot of people would be somewhat scared of using calcium in a patient that's on dig, or if there's any concerns that the patient may be dig toxic, right? Supposing you don't have the dig level back and you're worried about the dig toxicity, or even if you have the dig level back, a lot of people still don't want to use any calcium in the presence of dig. And that's based on a long-standing myth that says that if a patient has potential DIG toxicity and you give them calcium, you're going to turn their heart into stone, almost like Medusa is looking right at their heart. It turns right into stone, and then they get one really good contraction, and the heart turns to stone, and it never relaxes, and the patient dies in systole. I've heard people say that what it will happen is you try doing CPR on these patients, and it feels like there's a gigantic rock in their chest. And I ask those patients, have you ever seen that or witnessed that? And they say, no, but that's what I hear would happen. Well, we've got some literature here, and this is a article that was published in Journal of Emergency Medicine, which really dispelled that myth. There's other articles in Animals that have dispelled this myth also. And in this particular study, they looked at over 150 patients that were DIG toxic, and a lot of them were hyperkalemic. I think about 25 of them got calcium, and they found no increase in mortality or no increase in complication rate when giving calcium to these DIG toxic people. These are not just people on DIG, they're DIG toxic patients that are getting calcium for their hyperkalemia, and they had no increased incidence of adverse effects from the calcium. There's other articles out there also. This is the biggest one I know of, but there's no good evidence to support the long-held traditional myth that if you give calcium to patients that are DIG toxic, they're going to die in systole. So if you need to treat hyperkalemia, give the calcium. That's what the literature appears to say. Let me give you one other case. This was sent by Dr. Brad Peckler, who is the Associate Professor of Emergency Medicine at University of South Florida and also the Director of Simulation. He sent this a while ago also. It's been sitting in my files waiting to be presented. He had an elderly man with dementia who came in with weakness for 3 days. This guy's got a pretty good blood pressure, but a rotten heart rate once again. This patient's on DIG also, so that's the theme for today. He got a 12-lead EKG, and here is the rhythm. Now, notice that the patient's on DIG, but the patient really doesn't have the classic, QRS complex with that Salvador Dali mustache-looking appearance or hockey stick appearance on the end of that QRS. So that it doesn't have that classic DIG effect type of appearance. But once again, the patient has kind of a left bundle-ish type of pattern. There's little R's, deep S waves in V1, V2, V3. Not quite a leftward axis, but wide QRS. There's no Q waves in the lateral leads, which is also generally part of the definition of a left bundle. What else? Take a look at the rhythm here. Now, this rhythm is not quite as bizarre because you can actually figure it out. There's nice, distinct P waves that map out right across, if you use calipers, that map out right across this rhythm strip, and so there's P waves that are not being conducted. If you look at the PR intervals appear to be unchanging. If you map them out, again, the PR intervals are constant. So this is a Mobitz 2 with, let's see, 1, 2, 3 P waves for every 1 QRS. So this is a Mobitz 2 with a 3-to-1 conduction ratio. Sometimes people call this Mobitz 2 with advanced AV block, or simply call it advanced AV block. You can call it Mobitz 2 with 3-to-1 conduction, whatever it is. But that's what's going on here. The patient's got a very slow heart rate, and this is a little bit unusual for DIG to do this. DIG tends to cause more of a junctional automaticity, and it doesn't tend to cause a Mobitz in general. But when labs came back, this patient turned out to be hyperkalemic as well, and in a bit of renal failure, and the DIG level was top normal once again. So this is another example of a patient who happens to be on DIG and has a Brady dysrhythmia, an advanced AV block, because of the hyperkalemia. Maybe DIG is contributing, but this is not really a toxic DIG level, not overtly toxic DIG level. Anyway, what Dr. Peckler did in this particular case, he didn't want to take any chances. He just gave everything. He gave insulin, dextrose, albuterol, IV fluids, and furosemide to treat the hyperkalemia, and then he threw some digibine in there just in case there was some DIG toxicity that was contributing, and the combination of all of these different things fixed the EKG. It normalized as well. My guess is that this was primarily hyperkalemia causing all of these problems, but certainly the DIG can contribute to that. So a couple of nice cases there of patients that are hyperkalemic and on DIG. Take-home points here. Again, when the word bizarre pops into your head, so apparently there's 2 R's and 1 Z and 1 A. So anyway, we'll do some spelling this week as well. When the word bizarre pops into your head, regardless of how it's spelled, when you're looking at a rhythm, bizarre bradydysrhythmias, think hyperkalemia. Think about giving calcium and throw in some sodium bicarb. If you don't have an IV, give them albuterol in the meantime, and so on. Treat hyperkalemia. Bizarre equals hyperkalemia when you're looking at a 12-lead EKG. And the traditional contraindication of giving calcium in patients that are DIG is not supported by the literature. So if you're worried that somebody's hyperkalemic and they happen to be on DIG, go ahead and give them the calcium. The literature seems to suggest that calcium is safe. There's really no good literature that I've ever seen or heard of, including from the toxicologists, which indicates that if somebody is on DIG or DIG toxic, that calcium will kill patients. If you have an article that indicates that, please send it to me and I'll put it on the EKG video series. But I've never heard or seen an article that actually proves that calcium is deadly. I have seen articles like the one I showed you that says calcium is safe. And this issue comes up all the time. People always ask this question, can you give calcium to patients that are DIG toxic? And it appears that you can. And calcium is still probably the most important drug that you can give to somebody that has a dangerous potassium level. All right. So I hope that case was helpful, those 2 cases. And my thanks for sending in those cases. And I look forward to talking to all of you again next week. Bye for now.
Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City, and welcome to Soundbites Cases. In this Soundbites module, we're going to focus on bedside ultrasound of the gallbladder. I've divided this module up into parts 1, 2, and 3, and in this module, part 1, we're going to focus on the normal hepatobiliary imaging and ultrasound findings. Bedside ultrasound of the gallbladder allows rapid evaluation of patients presenting with acute abdominal pain to the emergency department, and interestingly enough, gallstone-related disease is now more commonly diagnosed in the emergency department with the increased advent of bedside scanning. Gallstone-related disease is not only seen in the traditional female population as described in textbooks, it's also being seen in men with rapid weight loss or weight gain changes, and also in the elderly. So let's begin this module with a review of the anatomy of the right upper quadrant, how to perform the exam, and the ultrasound findings in hepatobiliary imaging. Let's begin with a review for the positions for gallbladder sonography. As shown in probe position 1, the first position that's often used for gallbladder sonography is going to be known as the high lateral view, in which we're looking through the ribs. It's best to use a smaller footprint probe for this exam so that we can easily sit the probe between the ribs. We're going to be coming in a view that's very similar to the right upper quadrant view for the trauma fast exam. However, the probe here is angled more anteriorly than for the fast exam to image the gallbladder. The second position is known as the subcostal view, as shown in probe position 2 here, and it's best to roll the patient into the left lateral decubitus position so that the gallbladder is closer to the probe. From the subcostal position, we can push down directly on the gallbladder to elicit the sonographic Murphy's sign. Now, from both of these positions, we should rotate the probe from long axis with the probe marker towards the patient's right shoulder to the short axis configuration with the probe marker over towards the right side to completely inspect through the gallbladder for any pathology. Here's an illustration reviewing the anatomy of the gallbladder and biliary tracts important to bedside sonography. Here we see the gallbladder shaped as a pear-like structure, and we see the parts of the gallbladder, the upper fundus, the intermediate body, and the neck of the gallbladder towards the top of the image. Recall that it's impacted stones at the neck of the gallbladder that often cause symptomatic biliary colic and can lead to acute cholecystitis. We also see the cystic duct draining the bile from the neck of the gallbladder and joining into the hepatic duct, which is draining the bile from the liver. The confluence of the cystic duct and hepatic duct forms the common bile duct, and stones lodged within this area can cause choledocholithiasis. We also see the pancreatic duct joining to the common bile duct and dumping into the duodenum at the second part of the duodenum, located at the ampulla of Vater. Stones that may lodge here can cause gallstone pancreatitis. Now let's take a look at the ultrasound findings of a normal gallbladder. We see the liver to the left and the gallbladder just inferior to the liver to the right. Notice the areas of the gallbladder. We see the upper fundus towards the upper right part of the image, the body of the gallbladder, the intermediate part, and the neck of the gallbladder all the way down towards the left of the image. As we look closely through this gallbladder, we see that it has the typical darker or anechoic type appearance on bedside sonography, and that's because of the fluid within the gallbladder that is bile. We see here the absence of any significant stones, and remember that gallstones would appear as brighter or hyperechoic foci within the gallbladder lumen. Here's a normal variant known as a septated gallbladder, and we see a little septi, that little white line going through the middle of the gallbladder. This can be seen on bedside sonography and is not to be mistaken as pathology. Here's an illustration showing the relation of the gallbladder to the portal vein, known as the exclamation dot sign. The exclamation would be made up by the gallbladder, and the dot would be the portal vein. We see a thin white line connecting the gallbladder to the portal vein, known as the median lobar fissure of the liver. And this can be a very helpful landmark as one looks to find the gallbladder in relation to the portal vein. Also, we see the common bile duct and hepatic artery on top of the portal vein, making up the structures of the portal triad. Here's an ultrasound image showing the portal vein exclamation dot sign, and we see the gallbladder to the right making the exclamation, and the dot, the portal vein, to the left. Notice that the dot, the portal vein, has hyperechoic walls due to the fact that it's bringing greasy blood from the intestine to be filtered by the liver. We see the white line connecting the gallbladder to the portal vein that is the median lobar fissure, and posteriorly we see the inferior vena cava. Here's an ultrasound image showing the median lobar fissure of the liver in greater detail. Here we see the gallbladder, the pear-like structure to the right of the image, and the branching portal vein over towards the left. As we look in between the two structures, we see the thin white line known as the median lobar fissure of the liver. Now, the MLF can be a very important landmark as we look from the portal vein up to the neck of the gallbladder to inspect the neck of the gallbladder for any small stones that may be lodged there and causing biliary colic. Here's another video clip in which we can see the relation of the portal vein to the gallbladder in explicit detail. Notice the gallbladder to the right, the portal vein, the branching structure with hyperechoic or whiter walls towards the left, and we can see the area of the MLF, the median lobar fissure, connecting the two structures. And again, this is a very important landmark for walking your way up to the neck of the gallbladder to look for any small stones impacted at the neck. Also, looking for the portal vein can be very helpful in looking for a contracted gallbladder that can be difficult to identify on bedside sonography. Now let's review an image showing the anatomy of the portal triad. We see the first structure of the portal triad, the common bile duct marked in green. Notice that it connects the gallbladder down to the duodenum. While it's located to the left of this picture, in a real patient it would be located over towards the patient's right side. We see the posterior structure of the portal triad, the portal vein marked in blue, and we see the hepatic artery, which would be the third structure of the portal triad, over towards the right of this image, but would be located towards the patient's left side on real-time scanning. Here's a video clip showing the sonographic appearance of the portal triad, which we refer to as the Mickey Mouse sign. And here we see the gallbladder over towards the left of the image, and the portal triad making up the Mickey Mouse sign, the portal vein making up Mickey's face, and the ears of Mickey, the common bile duct making up the left ear of Mickey, and the hepatic artery making up Mickey's right ear. And this image is best obtained from a subcostal plane in a transverse axis with the probe marker over towards the patient's right side. Now we can place Doppler sonography onto the Mickey Mouse sign to further delineate the structures, and we see that the portal vein making up Mickey's face, the posterior-most structure of the portal triad, will actually light up with Doppler sonography. We can also see that Mickey's right ear, the hepatic artery, also has Doppler flow on Doppler sonography. However, the common bile duct, Mickey's left ear, fails to appreciate any Doppler flow due to the sluggish flow within the common bile duct. In this video clip, we can appreciate the common bile duct and portal vein in more of a long axis configuration. We've turned the probe so now the probe marker is over towards the patient's right shoulder, and we see the gallbladder towards the top of the image, and notice here we see two parallel channels towards the bottom aspect of the image here. Notice the portal vein with Doppler flow, and on top of the portal vein we can appreciate the common bile duct. As the common bile duct enlarges with obstruction, it will become as large or larger than the accompanying portal vein. Normal dimensions for the common bile duct is that it should be no larger than 1 millimeter for each decade of the patient's life. A common bile duct that measures across in diameter greater than 8 millimeters is universally enlarged. And when we measure the common bile duct, we're going to measure from inner wall to inner wall across the lumen of the common bile duct. My conclusion points for this Soundbites module going over part 1 of gallbladder sonography. Gallbladder ultrasound at the patient's bedside is a very helpful ultrasound exam in evaluating the patient presenting to the emergency department with acute abdominal pain. And hopefully through looking at this module, you know how to perform the right upper quadrant ultrasound examination and understand the anatomy of the hepatobiliary tract essential to bedside sonography. And also, by going through the footage, looking at the ultrasound imaging of the gallbladder and portal triad, you now know how to interpret the ultrasound images that you will obtain at the patient's bedside. So I look forward to seeing you back as Sono Access continues, and we go on to future modules focusing on gallstones and acute cholecystitis.